So welcome to today's webinar, examining how mental health conditions impact the incidence of COVID-19 infections. It's hard to believe, but worldwide, there's over 137 million infections with about 3 million deaths. And in the US, there's 32 million infections with 575 deaths. This webinar is so timely in terms of the interface between mental health issues and the incidence of COVID-19. In fact, on the Mental Health America's website, it says, as the number of cases of COVID-19 increases, so does the associated anxiety. For the general public, the mental health effects of COVID-19 are essential to address as the physical health effects. And for the 1 in 5 already have mental health conditions, or the 1 in 2 who are at risk at developing them, we need to take personal, professional, and policy measures now to address them. So this webinar is very timely. It obviously discusses the recent study that Dr. Wilson and Dr. Sullivan have conducted, and it helps answer these questions that are raised on the Mental Health America website, which obviously is front of mind to many of us. Now I'd like to introduce our presenters. Dr. Tom Wilson is an epidemiologist specializing in the design, evaluation, and the science-based improvements of population health programs, and he's the founder of Trajectory Healthcare. He has established a track record of bringing the principles of epidemiology to the healthcare data analytics space as an innovative way to help improve the health of populations and better optimize resources to reduce overall costs. Dr. Wilson also is the co-founder of the Population Health Impact Institute, which is hosting today's webinar, which the organization advocates for credible, independent, and transparent evaluations of organized populations' health and programs. Among other positions, Dr. Wilson has served in several positions with the Agency for Healthcare Research and Quality, AHRQ, which is a lead federal agency charged with improving the safety and quality of America's healthcare system. Dr. Wilson is a frequent speaker at national meetings on the use of evidence principles to drive care management programs, improvement and access, impact of population health improvement initiatives. Dr. Jesse Sullivan has been an active participant in local, regional, and national work to develop the standardized clinical performance measures. While the Chief Medical Officer of a New York Medicaid managed care plan, she used analytics to better align reimbursement with quality of care-driven objectives. She then served as the medical director for a $280 million implementation of a Medicaid waiver project in the New York Hudson Valley. She also was a founding member of the National Quality Forum, NQF, and served on NQF's board of directors. NQF, as many of you know, is a nonprofit, nonpartisan, membership-based organization that works to catalyze improvements in healthcare. She's also served in many other positions, including the American Academy of Dermatology, also on NCQA, the National Committee for Quality Assurance. She now brings her 28 years of experience in healthcare performance measurement improvements to her consulting work. So without further ado, Dr. Wilson and Dr. Sullivan.
Thank you.
So should I go over we did the introduction for 5 to 10 minutes. Then we'll present the findings of the study in 6 different areas: top of the line fundings, the history of our collaboration, methods we use, results, next steps, and conclusions. And then our 3 responders will speak for up to 5 minutes apiece on how they are feeling about what they just heard. And then we'll have an open discussion between the respondents and the moderator and the authors and perhaps other people on the line. Okay, next slide. Okay, I want to start. When I was an academic, we always put the findings like in the middle or the end of the article, but here we're going to start at the beginning. So these are the top of the line findings. This was a matched control study. We looked at mental behavioral health in 5 diseases. And what we found is the 5 diseases, which were well-known risk factors for COVID, were confirmed to be risk factors in our study. The one at the top, mental behavioral health, is not something that's listed on the CDC website as a risk factor for COVID, but we found it had an independent effect on COVID. So that's an important finding. Next slide. And we were wondering why that would be. So other work that I've done in the past, looking at the intersection between mental and behavioral health and physical diseases, we did what's called an interaction model. And these are the top of the line findings of the interaction model. The scale here, the odds ratios at the bottom, goes from 0 to 10. So you can see that the predictive value of this interaction effect between mental health and diabetes is 3.5 odds ratio. Mental health and hypertension, almost 3. Mental health and chronic obstructive pulmonary disease, over 6. Mental health and asthma, almost 3. Mental health and chronic kidney disease, 6. So we have a really strong interaction effect. We don't know why that is, but before you believe what we just told you, we think it's really important that you understand how we did this, why we did it, and the implications of the next steps. So Jesse is going to talk about our history of our collaboration. Go ahead, Jesse.
Okay, so I first met Tom almost 20 years ago. He was speaking at a meeting about how easy it is to be misled when you're evaluating a project if you don't have a proper control group. And we stayed in touch. And then when I needed to evaluate a very costly case management program, I asked Tom if he would help me set up a randomized controlled trial. So what's pertinent to that for this presentation today is actually what came next. I told him that most of the time we were retrospectively trying to evaluate something and we couldn't do a randomized trial. And he said, well, if you had a sufficient data set, if your data set was large enough, you could use something called propensity score matching to identify a control group within your data set. And so he and I decided to test that out with the data that we just used in our study. And we used propensity score matching to identify a second control group from the propensity score. And then we compared that to the randomized control group, and they matched very well. So, so then time went on, and earlier this year, Tom asked me if I was interested in working with him on this study. He had the access to the data from Colorado, and he was interested in looking at the mental health effects on persons who had a COVID infection. And I said, well, that's great, we should do that, but we should also look at the mental health effects on everyone else who didn't get COVID, but who's been living with the epidemic. And so we want to do those two studies, but at the time, we only had 4 months of COVID data. And so we couldn't really start with those studies. And we decided to begin with the background study, where we would look at the effects of having a pre-pandemic diagnosis of mental health on persons who subsequently developed COVID, and compare that to a similar group of persons who did not get COVID. So that's how we started. Next slide.
And the methods that we used were, I'm an epidemiologist by training, and so epidemiologists look at epidemics, right? And for 19 years, nobody really knew what an epidemic was, because we don't really have them, classic epidemics, like they did 200 years ago, until a year ago, right? So on the left here is an epidemic curve, and we've all seen this. It's in the paper every day, right? And what it shows is cases over time, new cases over time. And this is from like a year into the epidemic. So you see it goes up, it goes down, it plateaus, it goes up again, it goes down, and it may be going up again, who knows? So that's a classic epidemic. And epidemiologists for 150 years have been using analytic tools to try to understand why it went up, why it went down, et cetera, et cetera. Well, when I left the university world, I came to a Blue Cross plan, and I'm an epidemiologist. I don't see any epidemics 25 years ago. So I said, what we should do is create virtual epidemics, as if everybody got the disease on the same day, everybody had a heart attack on the same day, everybody got ovarian cancer on the same day. So in a classic epidemic sense, the graph in the middle shows what that would look like, which is absurd. It's just one long line. It's just all the cases happen on the same day, as if there were a plane crash or something. So what do we do in this virtual epidemic model? we track covariates and cofactors over time. So I'm showing here on the right, tracking of resource use over time. This is actually a cancer population. And you see that classic trajectory look, which is very similar to what Jesse just showed you when we did our study for a case management program. So that's our basic method. We're going to look at what happened before, and later we'll look at what happened after. This study is only what happened before to predict the incident event, which was COVID-19. Next slide. Jesse?
So the first question is, how did we identify people who had COVID? So this is the all-payer claims database. So we're looking at health insurance claims data, which is coded. And we used the ICD-10 code U07.1 to identify a COVID patient. And that code is the code that has been designated for persons with a COVID infection that has been verified by laboratory testing. And that's the code that we used. And we looked at the principal, we only looked at the principal diagnosis on a claim. So every medical bill has, a lot of things listed, but we just looked at the primary diagnosis. And we took as the date of the of COVID, the first time a patient had a COVID diagnosis. Then we wanted to, I talked about how I learned from Tom how important a control group is. So then we needed to have a control group of persons who did not get COVID, but we wanted them to be similar people. So how do you decide what makes someone similar? So obviously for COVID, we know that age is very important. And we also looked at sex, at gender. But we wanted some kind of estimate of health status. And we're thinking about how we can do this with claims data. And we decided that we would use spending on healthcare in the previous 12 months as a way of estimating health status. So we took all of the costs that each person had in the previous 12 months, and we divided those into 4 quartiles, and we matched patients and non-patients on the quartile of cost. And I think that's based on the assumption that if someone is obtaining more healthcare services, they're probably sicker, have poorer health than someone who doesn't use any healthcare services. But that leads us to the next thing we had to look at, because this is a insurance claims database. Oh, well, we have to go back to the, yeah. So we're looking at insurance claims data. So if there's no data, it could mean someone's healthy, but it could also mean they didn't have insurance. And so we needed to have some way of kind of matching on, was everyone enrolled? And we looked first at the enrollment data, and it was not very reliable. It looked like it didn't really make sense. So we made an estimate of the duration of coverage. We took for the COVID patients, we took the claim on the COVID date, and then we looked back, when was the first time in the previous 12 months that they had another claim? And we assumed that they were continuously enrolled in between, which might not be the case, but that's the assumption we used to estimate coverage. And then finally, we had an index date. So I explained that we had an index date for the COVID patients was the first date that they had COVID. So all of those dates were in March, April, May, or June. And to pick a matching person, we picked someone who had any kind of claim, healthcare claim, in the same month, and that became the index date for the person in the control group. And then finally, I wanted to say something about social determinants of health. So we clearly understand that race, ethnicity, schooling, socioeconomic status are extremely important variables in considering a similar population. But the race data is usually missing in the data file we were looking at. So we did not do that for this study, but we are going to look at how we can do that in a future study. We'll talk at the end. So the next slide, please.
And before we talk about this, Jesse, can I say something about propensity score matching? We did this matching protocol. We've brought it up several times. It's not an exact match. It's called a propensity score match. And you use the variables that we have here. we develop a model to say, what's the probability that somebody has COVID based upon these variables? And you get a probability, and what you match on is the probability. So that's how we do our matching. And now Jesse's going to describe how well this process worked. Go ahead, Jesse.
Right. So these 5 graphics are the 5 criteria that we used for our matching group. So I wanted to look at the age band first. Click, click. So stop there. So the first 2 clicks, the bottom 2 bars are all of the patients. So the very bottom bar is patients who did not get COVID, and there's over 1 million patients in that before we did the matching in that bar. And the bar just above it is the patients who got COVID. And you can see, if you look at that the COVID patients are in general older than the whole total population, and that is as you would expect. And then the 2 bars above it are, the top is the COVID group and the bottom is the non-COVID matched group. Now the 2 groups are the same size. Each group has 7,599 participants, and you can see that they're very well matched in the age bands that we looked at, those 3 age bands. So we looked at sex, and again, the bottom two bars are before we did the matching, and there's very little difference. There actually is 1% difference, 1% more males in the COVID group, and then after we did the matching, they matched directly. So if you'll do 2 clicks for the next slide. So again, the bottom bars are the before we did the matching, and you can see the very bottom group is the patients who did not get COVID, and the cost quartiles displayed there. The darkest bar is the most costly. You can see they're all the same length, and that's by design because we took the whole population and divided it into quartiles. So you know, they're all equal. But if you look just above that, the group of bars is the COVID patients, and you can see that they are much more costly than the non-COVID population. And again, this is costly not after they got COVID. This is costly before they got COVID. So this speaks to our assumption that higher cost utilization reflects poorer health, and one would expect people in poor health would be more likely to have COVID. And then you can see again that the top 2 sections of bars after we did the match, the 2 groups match on the cost quartiles. Then down again, if you'll do 2 clicks.
Actually, one more click.
One more click. This is the month of the index month of the health service. And so the dark green bar is March, and then April is lighter green, May and June is as we go up. And you can see that at the beginning in March, there were very few patients with COVID, but people who did not have COVID were still going to the doctor at that point. So there were lots of health services being provided in March, but and then in the top 2 bars, you can see again that the groups are now matched, that when we picked our control group, they were well matched. And then finally, the estimation of duration of coverage, if you'll do 2 more clicks. I think what's interesting about this is that both before and after matching, there's not a tremendous difference between the COVID population and the non-COVID population in terms of estimated duration of coverage. And in fact, most of the subjects in the study appear to have been enrolled for the full year. But what is interesting is at the far left-hand side, those are the persons who had less than 1 month of coverage. And you can see that there were many more COVID patients with less than 1 month of coverage than non-COVID patients with 1 month of coverage. And that suggests that there are a number of people who had no health coverage, had no insurance coverage before they got COVID, but presented with COVID and then were enrolled in some kind of health care. You may also notice that before we did the matching, our COVID population was 8,153 persons. And after we did the matching, both groups had 7,599 persons. So there were 500 COVID patients who failed to match, and all of those patients were in this bucket of less than 1 month. So our study is not really looking at the people who had no health history before they joined. Next slide. So when I'm talking to people about how to do healthcare quality, one of the things I always talk about is compared to what. and so we knew we were going to look at mental health. What is the impact of having a mental health diagnosis before you get COVID? And we didn't know what we were going to find. We didn't know if there was going to be an association, but we had a sense of whatever we find, we need to know how it compares to something else. What's the difference between mental health and other conditions? So we looked on the CDC website, and the CDC maintains a list of conditions that have been associated with more severe COVID, and they rank those associations by the level of evidence supporting them, and the list has evolved over time. So we were looking at the list back in February. It's not exactly the same now, but from that list we selected these 5 diseases. These are diseases that can be identified through claims data, and the top 3 were listed by the CDC as having the highest level of evidence, and asthma and hypertension were listed as having mixed evidence. And we did that on purpose because we wanted to see where does mental health fall compared to other things that we know. So then how did we identify? So I talked about how we identified COVID by that one ICD-10 code. So how did we identify people who had these other diseases? We used the clinical condition software of the Agency for Healthcare Research and Quality, which takes diagnosis claims and groups them to define a diagnosis. And that's what we used for these conditions and also for mental behavioral health diagnosis. And in every case, we used the primary diagnosis in a claim. So we looked we established the index date in our control group, and then for both COVID patients and non-COVID patients, we looked in the 12 months prior to see if there were any claims with a primary diagnosis of one of these conditions. Next slide.
Okay, and here are the results. Now, of course, we matched on age and sex and resource use and coverage, so those have no impact on what we're now looking at. So we then looked at mental health and then 5 other conditions. Then we compared the prevalence of these conditions in the COVID group and the non-COVID group. And the high-level finding is in every case, the COVID patients had a higher prevalence rate of these conditions than did the non-COVID group. For mental health, it was 26% to 18%, hypertension 19 to 14%, diabetes 18 to 11%. COPD, 7 to 3%. Kidney disease, also 7 to 3%. And asthma, can't read it, 6% to 4%. So just as a background, this is what we did. Now, next slide. And then we put these conditions and in a multivariate logistic regression model by themselves. Of course, age and gender, etc., were already controlled for. So we just put them in all together, so they're sort of controlling for each other. We create an odds ratio with 95% confidence limits. And if an odds ratio of 1 means no effect, right? So if any of these bars are cross 1, that means it wasn't statistically significant. And I've got at the bottom here a reference just to show you how that works. But all of the conditions are above 1. And, diabetes, essential hypertension, chronic kidney disease, asthma, COPD, they were all pretty well-known factors. Mental and behavioral health is not a well-known factor about predicting COVID. So look at the odds ratio is comparable to what we see with these other ones. In fact, it's about the same as diabetes. It's even a little higher than asthma. So this is an important finding. Mental health should be considered. Go to the next slide. Now, we weren't comfortable with stopping with just the independent effects of mental health. We want to know, how can this possibly work? Why would people with mental health have a higher incidence of COVID. And some of my prior work, I know that people with mental health, when they also have a physical disease, they cost more, they have more serious health problems. So we created a model which, and these models are all compared to people with the condition, without the condition of COPD, for example, in this case, and without the mental health condition. So they're all comparing to that. That's the reference. So what you see here clearly, the third thing down is mental behavioral health and COPD. The odds ratio is over 6. It's got a wide confidence limit because there's not a whole lot of people, but it just overwhelms the other odds ratios for everything else. And now, the first one is COPD by itself, no mental health. It's still almost 2. It went down a little bit from the individual effect. It's still important by itself. The second one down is mental health by itself. It's about 1.5. Still important independently, but it's hugely important when the two are joint in a joint relationship. Now the next slide. This shows another example just to show you I'm not like just making stuff up here. This is chronic kidney disease. The same kind of finding. Mental health and CKD has a huge impact on getting COVID compared to mental health by itself, compared to CKD by itself. I'm not going to show all of the forest plots for all diseases, but the next slide shows the summary of the interaction effect. Next slide, Gary. So these are all of the I'm not showing all the variables in the model. These are all run through different models. Mental health and diabetes, the odds ratio is almost 4. Mental health and hypertension, it's almost 3. Mental health and COPD, over 6. Mental health and asthma, nearly 3. Mental health and CKD, a little over 6. Reference is 1. So this is a big deal. Next slide. Now,
Okay.
Go ahead, Jesse.
Well, this is kind of a footnote to our study because this is a raw comparison. We didn't do an analysis of this for significance, but we thought that people would be interested in some of the sub-diagnoses. So that's why we did this. So in the table to the left, you'll see the number of persons with the so let me say these are the subcategories within the ARC grouper for the mental behavioral health diagnosis. So these are the subcategories that make up the mental behavioral health group. And we've rank ordered them here by the ones that have the highest prevalence ratio difference comparing COVID patients to non-COVID patients. So for schizophrenia, the ratio of the prevalence among COVID patients compared to the prevalence in the reference group is 3.8. That's the highest. And then the lowest it goes down to actually just under 1. So from top to bottom is the highest to the lowest prevalence ratio. And then I've just made this more visual on the right. This table is just showing the number of persons. The orange is those with COVID and the green is those that don't have COVID, and the number of persons who have each of these mental health diagnoses. And so you can see, even though suicidal ideation has a high prevalence ratio of 2, meaning it looks like it's a significant risk, there's very few persons in that cell, but there are a lot of people in depressive disorders, in anxiety disorders, in trauma and stressor-related disorders. So again, this is without a statistical analysis, but we knew people would be interested in the more specific diagnoses. Tom, do you want to add anything?
No, that's fine. That's great. Nope. Next slide. Okay, so just in conclusion, and we're actually doing this in good time, Jesse. First, we showed, I'm just telling you what we already told you, but mental and behavioral health is an important independent predictor of COVID. Also, our study validated the known effect of 5 physical diseases. Perhaps most importantly, our study shows that the interaction, people with both mental health and a physical disease, was much more impactful than each condition by itself. And we'd like to explore that in the future. Just so you know, we did submit a preprint of this article. to the Social Science Research Network, and there's the citation. And we just got news yesterday that was listed in the top 10 of SSRN public health articles downloaded in the past 60 days. So that's pretty cool. Next slide. Jesse?
Okay. So these are the next steps that we have in mind, and we look forward to hearing from our panel and also from those who are listening about some other ideas about what we might do with this. So first, we already mentioned that we really want to consider social determinants of health. And while we don't have race or schooling or economic data, we intend to use zip code as a way of approximating social determinants. Then, we talked about our initial study was we wanted to look at the impact of COVID on the use of health services before and after the epidemic. And, we'll focus maybe particularly on mental health services, but I think other services as well. We believe that as things started closing down, people went to the doctor less. And we want to see what kind of patterns we can see, particularly in mental health. And I know in my own family that my grandchildren range from little to teenagers, and the teenagers have found this particularly difficult, and I think that's been true across the nation. So I think one of the things we want to look at is the overall impact of mental health. And then very importantly, Tom began this by wanting to look at the effect on mental health of a COVID infection. So we want to look at the effect post-COVID infection of mental health utilization on people who had COVID. And we think our model particularly allows us to be careful of saying that, is it an exacerbation of prior mental health issues, or is it new? Claims data gives you the ability to look a long period before and after. And here below we've cited an article that was published last week that got a lot of attention, calling attention to the neurologic and mental health effects of a COVID infection. So that's something we definitely want to explore. And then the last thing we really want to ask for all of your input is that, we're very impressed with the interaction of mental health with physical disease in terms of increasing the risk. And we want to think about how we can explore that more carefully. What does it mean that mental health is a risk factor? Is it behavioral? Is it something physiologic? Is it because of the influence on social determinants? How is it that mental health has this impact on COVID? So how can we explore that? Tom?
That's wonderful. I guess we're going to turn it back to Gary and get some interesting, surprising input, I hope, from our respondent panel. Gary, you want to take this over? And
Sure. Well, Dr. Sullivan, Dr. Wilson, thank you so much for this very insightful, study that obviously has some implications on population health related to future clinical and financial trajectories and outcomes, et cetera. So it's my pleasure to introduce our very esteemed panel of experts. I'm just going to briefly announce each person and a little bit about their background and order of presentation. So first up is Dr. Pat Salber. She's a physician executive and health journalist who founded and serves as the editor-in-chief of The Doctor's Ways In. She was double boarded an emergency physician at Kaiser Permanente until transitioning to a national executive position as the organization's first director of national accounts. Currently, she serves as a consultant to CMS and speaks and moderates at both national and international healthcare conferences. And she's published dozens of peer-reviewed journal articles, trade publications, and 2 books. Next up, we have Dr. Rachel Nolan. She is current fellow at the Royal Society of Public Health. Her professional roles include assistant professor and concentration director for health services management in the Public Health Science Division of the University of Cincinnati College of Medicine. She is an experienced and well-known population prevention science researcher, and she is certified in public health, gerontology, and grief recovery. Dr. Nolan has served as an advocate for the needs of persons affected by chronic and terminal illness and their families. And then finally, we have Dr. Deborah Viola, who serves as the Vice President Data Management and Analytics at Westchester Medical Center Health Network. In her position, she directs information management activities across the network, including business intelligence, clinical efficiency, strategic analytics, and population health analytics. Prior to joining the Westchester Medical Center, Dr. Viola was associate professor, director, and co-founder of the doctoral program in health policy and management at the Center for Long-Term Care Research and Policy at New York Medical College. She remains on the faculty as an adjunct professor of health policy management. So without further ado, Dr. Salber.
You're on mute.
Yeah, you may be on mute, Dr. Salber.
I planned on not being on mute, but at any rate, let me start out by saying I really want to congratulate Jesse and Tom on a fascinating paper that I think has really gotten our brains going. It's really made us ask a lot of questions. And Jesse kind of hinted at this at the end of her remarks. The big question is why? Why is mental health a predictor of an increased risk of getting COVID? And before I explore that, I just want to start out by saying that we all know there's a lot of factors that increase our risk of getting COVID. Some of them belong to the virus, virulence, infectivity, transmissibility. Some belong with us, the patients, our age and our sex and our underlying conditions. But I recently published a paper on our site that was written by a cognitive psychologist, Dr. Brendan Murray, in which he proposed that discuss the critical importance of human behavior in our response to COVID-19. And we kind of know that from the exhortations we get from our public health people telling us, wear your mask, social distance, wash your hands, all that stuff, which is human behavior. And by the way, it is the only one of all these factors of which we have complete control, right? Everything else, unfortunately, we can't control our age, or some of these other factors. So, so the question to me, as Jesse said, is how can we understand this impact of behavioral health and COVID? Is it a behavioral pathway? And I have to say, when I first read this, that was the first thing that came to mind. Well, of course, a lot of behavioral disorders have thought disorders, right? You have your thinking may be more disorganized than somebody who doesn't have that behavioral disorder, even if it's just depression, where we know it alters people's thought patterns, as well as schizophrenia, which we know that as well, and some of the other disorders. But you can't rule out that it isn't a physiologic effect. And as I started thinking about it, I said, well, yeah, the obvious one is a lot of people with these behavioral disorders end up on therapeutics, and a lot of these therapeutics, particularly the ones used to treat thought disorders like schizophrenia, have metabolic effects. So they lead to weight gain. Some people get diabetes. These are all things that are a result. But then I raised this question to myself, and I don't know the answer. Maybe somebody listening does. Is there anything different about the physiology of somebody not on drugs who has a mental health disorder that could actually, that could perhaps increase their risk of COVID? I know that sounds far out, but I think when we have a new finding like this, we really need to open up our thought processes and explore all of these things. And then this whole idea of social determinants of health. How would we sort out other kinds of behavioral issues from what we know is a common outcome, unfortunately, for many people with mental health disorders, that they end up losing their jobs, they end up being in poverty as a result of not being able to work. They also may have different living situations. They may be living in group homes or homeless shelters or even in homeless camps, places where your exposure is going to be different. I don't know how you're going to sort that out, Jesse and Tom, using claims data, but it's an interesting thought. And then perhaps it's both, perhaps it's a mixture of both, which of course I think will make it much harder for us to sort it out. And then the last thing that I wanted to talk about is, I think we've raised the issue of whether we could take this finding, if it is confirmed by others or perhaps your future work, and apply it to future pandemics, because we now know that there will be future pandemics. And I think that in order for us to be able to do that, you'll need to take this model and apply it to other kinds of infectious diseases, if we just want to stick with infectious diseases, and show that mental health has, the same kind of impact, for example, on flu or certain rampant sexually transmitted diseases and so forth. So to me, Tom and Jesse and audience, I think one of the major takeaways of this paper is that this methodology, and by the way, Tom and I did do a paper where we used this methodology looking at the impact of comorbid conditions on the cost of care of Alzheimer's patients. He kind of alluded to it in the middle of this talk. But I think that methodology allows a relatively quick assessment of potential associations, right? I mean, this didn't really take all that long by research standards in my book. And although it's not without its limitations, because we all know claims data has a lot of limitations, I think studies like this can really play a very important role in uncovering new possible relationships between conditions, and that should stimulate further research into the topic. And I'm really glad to see that you guys already have your thinking caps on, and you've got a lot of ideas of what to do next. So thank you very much for the work that you've done and allowing me to participate in this panel.
Great. Thank you so much. Dr. Nolan.
Yeah, thank you. So there's a couple of things that come to mind when I'm listening to the results of this finding. So the first thing is, recent evidence out from Canada has showed that there's multiple variants that are affecting the country right now, and it's probably only the country that we know of that's being affected by 3 different variants. And it's interesting that when we move and we continue these types of studies, if we look at the different variants and the effects that they might have individually, is one more variant impacted by mental health as opposed to another. So I think that would be one future step that we need to look at. The other thing too is, not all mental health is clinical or pathological. Clinical health or mental health can start off through grief, through symptomology from losing a loved one. The National Institute of Health suggested that about 4 grievers are produced per death, and that was about a study that was produced about 5 years ago. The National Science Foundation just did a new study looking at COVID deaths only, and they're showing about 9 grievers are produced per COVID death. So if we think about that, when we lost a loved one, there's a huge impact upon our mental health that isn't necessarily clinical or pathological, but it does impact mental health. And people with mental health tend to sometimes take less care of themselves, tend to go to the doctor less. These are all associations that are reported in the literature. And as some of the other guests have alluded, there's also some association with reporting poor mental health and an increase or a greater risk of chronic disease, infection, and so forth. So I'm thinking that, some of this is really good to look at from a clinical and a pathological perspective, but it's also to look at just from basic mental health, from a grief, normal emotion, day-to-day functioning type of structure, and also, just looking at overall the impact, the mental health impact both before and after. So what is it like to live in a pre-COVID world? What is it like to live in a post-COVID world when you've lost a loved one? Another study that came out today suggested that from our children, about anywhere from 15 and younger, that they expected that 27, I think, to 43%, it's actually a wide range, have reported loss of a parent during this time. So when we're talking about age, I know that Dr. Sullivan suggested, that we were looking at 30 and younger. It's going to be interesting to see how this has impacted the children. And she suggested that her grandchildren were her teenage grandchildren were specifically affected by their mental health thank goodness, perhaps maybe none of those have lost a parent, but there's going to be all these different effects that we need to look at, not just from a clinical pathological perspective, but also just from a loss perspective and the effect that that has upon our mental and physical health. The last point that I want to make is Zoe Donaldson, she's a colleague of mine, and she's actually looking at grief in the brain. So the impact of grief and having a loss in real time. She's doing MRI studies with moles, and we can see that there's a huge impact neurobiologically on the brain. We've experienced the loss of a loved one, or we've experienced a lot of loss in our life. So it'd be interesting to see if we could do potential, maybe look at MRIs and see what type of effect COVID is having on a neurobiological perspective in individuals who are experiencing COVID or have experienced complications because of COVID, or even have experienced the loss of a loved one because of COVID.
Great, thank you, Dr. Nolan. Excellent comments. Dr. Viola.
Yes, hi, thank you. And okay, so going last, I have to think about my comments, and admittedly, I'm going to be a little bit more myopic, and I'm going to focus a little bit on the actual model and your results. So I do think that you have a systematic error with your results, and it does largely get back to perhaps missing these social and economic factors or social determinants. And so I want to be careful here. I don't think it's simply an omitted variable bias. That wouldn't concern me. I think it's more confounding variable bias, right? Because these missing factors impact both the outcome here, COVID, right, and all these other regressors, right, everything else. So it's not to suggest your finding doesn't hold. It certainly may hold, but I do believe that your findings are distorted because you are missing these other factors. So you ask yourselves that, right? What is it about exposure to mental health that could put someone at higher risk of COVID? Or I think you talk about these possible mechanisms where mental health can lead to infectious disease. And Dr. Selber hit on one of them, especially in this population, right? So mental health folks are very likely to live in congregate care settings or receive care in these settings. And so it's very possible that what your data is showing is a more heightened need for how we manage infectious diseases like COVID in these congregate care settings, right? So we don't know that because that's part of that data that you're missing. And then you have to ask yourself, how will you get this data, right? So I'm just limiting myself right now to the data set that you have at hand and how you might think about capturing these. So you can use a measure like an area deprivation index out of the University of Wisconsin. I've worked with that. What I like about it, it captures something like 17 different census variables and comes up with this index. And then the index is actually scaled within states. So like here in the state of New York, I use the state level deciles, and it gives you a sense of relative deprivation between really small geo area census tract, but you can, use an aggregate up to zip level. And I'm sure some folks will suggest then that's an ecological variable. So maybe I know Tom, someone like yourself, an epidemiologist, might shout out ecological fallacy, but that would be a fallacy, right? Because how else do you really capture all of these structural impacts on behaviors and health outcomes, which is something that you're interested in, without having a variable that represents that. So there are going to be things like discriminatory housing policy, or the fact that there's a pharmacy desert or a primary care desert in these geo areas. So you will need those variables. My concern, though, is will we miss something at the individual level? Because again, in this case, mental health. Is it possible that you're capturing a large group that is represented in these congregate care settings and you just don't know it, and they're getting COVID because of their care setting or where they reside? I also wanted to shout out, I know you mentioned race many times. Colorado is 85% white, 4% African American or Black. So I don't know with how you're doing your modeling and the amount of data you have is really race. I just want to throw that out there. But if you use a an ecological variable, I do recommend the ADI, which, by the way, does not pull in race and ethnicity. There's no need to, because when you look at deprived areas, they'll define themselves, right? So I throw that out. So I think this was great study. It really intrigued me to think about mental health and COVID in that way. I had not really thought about mental health being a predeterminate factor, like being in the hospital here, certainly seeing the impact of things like diabetes. But again, I would just caution you a little bit. It's possible that, I think it's not possible. You do have the systematic error, I would say, and so maybe that you're distorting the measure of association of your finding between mental health and COVID. So just want to throw that out there. But thank you, and thank you so much for asking me to participate.
Okay, well, thank you, Dr. Viola. Let's pause, and Dr. Wilson, Dr. Sullivan, why don't you feel free to respond to any of the comments from the responder panel?
I'll have a brief response, and then maybe we can open it up. I want to start with the last, because I have a very short memory, right? So I'm going to start with Deborah. Had I known you were going to say that, Deborah, I wouldn't have invited you to the meeting. No, I'm just joking. No, I absolutely agree with you. I totally agree with you that a limitation.
Not fair. I gave you a warning.
I know. No, I'm just joking. I'm just joking. I totally agree. We knew this from the beginning. We did not have any geo data when we first got this data set, and we knew it was a big problem. And we had requested that. We finally got it just recently. So now we have zip code data. And with that, and Jesse responded to it, we will create, and maybe you can help us, an area deprivation index. We have, all the census variables per census, per zip code. And we will look at that and see what impact. And I believe it will have a huge impact. When I first got out of graduate school, I was at UC Berkeley looking at social, back then we called them psychosocial predictors of health, right? But social class was the most important predictor of bad health, and it's hard to get it at an individual person level. But as you said, there is a potential when you get it from an area level and you attribute that geographical median income, let's say, at a zip code level to an individual, there is a potential problem with ecological fallacy. So I would say, and what's the alternative, right? I mean, basically, it's a wonderful, I'm much more inclined to do this than I used to be, as long as we recognize it. We recognize the problem and we move forward. And just that, so that's my comment on you. And with Pat, I love your comments, and I think on the the physiological versus behavioral aspects of mental health, we should look at that. And Rachel, you get into some of the detail on the variance. We probably will never get variance in this data set, and also we only have data up to potentially the end of 2020 prior to the variance showing up in great detail. So if we can convince Colorado to give us more data through every quarter, we may be able to address that issue of the variance. And also your comment about grief as a trigger for mental health factors, that is huge. I'm not sure how we can get to it in claims data, but maybe we can figure out how to combine the claims data with some sort of localized survey or something to understand level of grief. So those are my general comments, Jesse. What do you think? What do you have to say?
Yeah. Well, I just, I appreciate everyone taking the time to comment, and I completely agree that our finding is, well, so I have friends and family members who are therapists and psychiatrists, and all of them said, well, why is that? And so, Deborah, to your point, I mean, if the whole reason is because of some of these other confounders, that we need to do our best to tease that out, and I hope we might be able to get your help to do that, because I think that's extremely important. I mean, it's not, I think with kidney disease and COPD, even diabetes. We know the virus seems to have a lot of effects on inflammation in the circulatory system and small vessel effects, and so kidney disease makes sense and lung disease makes sense. And but mental health doesn't immediately make sense, and I think we have to figure out what is it we're looking at, and yeah, mental health might be a marker for something else. So that's what we have to understand. So so we look forward to opening up to the people who are listening and hearing your thoughts on how we can do this. I mean, we have a claims data set. I think there are more things we can do with a claims data set. Some of this, probably needs to be explored other ways other than claims data. So, Pat, I really liked your remark that this shows that using claims data can allow a somewhat quick and easy way to maybe find some associations that you then need to do other kinds of studies to understand better. Rachel, to your question about the variants, well, Deborah knows more about the current coding than I do, but at least as far as we looked in the claims coding data, we weren't at, there was no code for the different variants. So people who are doing study using electronic records and the laboratory data could look at that, but we couldn't do that with the claims data. So so let's open it up, and I hope maybe we have some questions from responders, or maybe our panelists would like to react to each other.
Right. Well, just real quickly, let's see, Judy, any questions that come in through the chat room box or Q&A? That's worth.
We did have a couple, but I think they were mainly answered. One wanted to know, is there a clinical hypothesis for why persons with mental health effects might be more susceptible to COVID and its effect on the body's immune response?
I think we sort of talked about that a little bit. That's good. Well, I would like to ask the panel, starting with Pat, who started this out. Pat, do you have any general comments of what we said, what the other panelists said?
Yeah, I do have one comment. I do have one comment, since we spent time talking about why mental health, and it isn't just an academic exercise. I don't know, Jesse, if all the therapists in your family just wanted to know because they're intellectually curious, but you're a quality person, so you probably think like me, and you say the reason why we want the answer to that question is because the interventions that I would design to take on reducing risk of mental health would be very different if it was related to their drugs or related to their inability to comply with, with the social distancing and so forth. And so it's more than an academic exercise. I think it's critically important if we're actually going to start talking about how do we reduce or prevent the impact of what you saw, the increased risk of mental health on COVID.
And Rachel, do you have any?
Yeah, so, when we look at coping skills with regards to grief and mental health, our coping skills, they can be adaptive or maladaptive. And the adaptive ones are the ones that we would think of, like, trying to maintain routine, trying to maintain some sense of normality, keeping up with, health, exercise. But there's also those maladaptive coping skills, which we consider our public health risk factors. And those would be like drinking alcohol. What's a huge thing we've seen during COVID? What's a huge uptake that we've seen? The number of people who drink alcohol, that has definitely increased. So we need to look at those effects of those maladaptive coping behaviors as well. And people who suffer chronic stress, whether it's stress from job loss, whether it's stress from income instability, or just being on lockdown, because that was extremely stressful for me and my two college-age sons, and not being able to socialize, what kind of impact does that chronic stress have on the ability? Because we know that chronic stress has been associated with decreased immune function. It's been associated with that increased fight or flight response. And over time, both of those can lead to cardiovascular issues, COPD issues. So there's a lot that needs to be teased out here. I absolutely agree, but it's fascinating to me.
Wonderful. I might say that we're almost done here, but Jesse and I have already started on the next paper. We've got 3 more months of data. We started creating the area deprivation index, Deborah. So we hope to be back out in front of this audience in 6 weeks or so. It's very ambitious, but we're ready to. We've got maybe 2 or 3 more papers in mind based upon what we already have. So thanks everybody for attending. I really appreciate it. Gary, do you want to final?
Yeah, just the contact information is on the screen. We will be sending a copy of the PowerPoints out to the attendees, so you can certainly follow up and ask any questions. I want to definitely thank both the presenters and the respondents for a fascinating discussion. As someone who's more of a layperson on these issues, to me, the dialogue about the methodology, among other things, is so important. First of all, mental health, obviously, everybody agrees, is very, very important, and how we use the Colorado all-payer data set as a convenience sample, how you generalize that, how you factor in the comorbidities, how you basically generalize the findings, how you identify a clinical pathway that's actionable. All this is very, very important. So Dr. Wilson and Dr. Sullivan have agreed to do a follow-up webinar, so stay tuned.
Thanks,
we'll
everybody.
have more details. Yeah, we'll have more details on that shortly. So thank you for attending today. And this concludes today's webinar. So everybody have a great day. Thanks so much.
Bye-bye. Thanks, everybody.